Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. After the presentation, there will be a question-and-answer session. To ask a question at that time, please press star 1 on your touch-tone phone. Please unmute your phone and record your name at the prompt. This conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the meeting over to Ms. Marisa Scala-Foley. Go ahead, ma'am. You may begin.
All right. Thank you so much, Katie. Good afternoon, everyone. Good morning to those of you who are on the West Coast. As Katie mentioned, my name is Marisa Scala-Foley. I work in the Office of Policy Analysis and Development in the Center for Disability and Aging Policy at the Administration for Community Living. We do thank you for joining us for this month's webinar, which is our latest in now a 2+ year-long webinar series focused on the Patient Protection and Affordable Care Act, also known as the Affordable Care Act or the ACA, and its impact on older adults, persons with disabilities, and aging and disability organizations. Our webinar series is designed to provide aging and disability organizations with the tools that you need to participate in ACA-related efforts in your area, such as accountable care organization, state integration for dual eligibles, health homes, managed long-term services and supports, and more. Today we continue our multi-webinar series that we began last year that focuses on integrated care and managed long-term services and supports. As an increasing number of states move toward developing and implementing managed long-term services and supports for older adults and people with disabilities, there are lessons to be learned from states that have already made this transition and in some cases have been doing this for decades. So today we will examine promising practices for managed long-term services and supports from states with existing programs. And all of this is discussed in a report that was put out by Community Catalyst called Putting Consumers First, Promising Practices for Medicaid Managed Long-Term Services and Supports. Before I introduce our speaker, we do have a couple of housekeeping announcements. First of all, if you have not yet done so, please do use the link included in your email confirmation to get onto WebEx so that you can follow along with the slides as we go through them and also ask your questions when you have them through the chat function in WebEx. If you don't have access to the link we emailed you, you can also go to www.webex.com, click on the Attend a Meeting button at the top of the page, and enter our meeting number, which is 668-532-713. Again, that meeting number is 668-532-713. And the passcode is ACL Webinar, all one word and all in caps. And that's ACL Webinar. If you have any problems getting into WebEx, please contact WebEx Technical Support at 1-866-569-3239. Again, that technical support number at WebEx is 1-866-569-3239. As Katie mentioned, all participants are in listen-only mode. However, we do welcome your questions throughout the course of the webinar. There are 2 ways that you can ask your questions. Throughout most of the webinar, you will need to ask your questions through the chat function in WebEx. You can enter your questions, and we will sort through them and answer them as best we can when we take breaks for questions during the webinar. In addition, after Alice wraps up, we will offer you a chance to ask your questions through the audio line. When that time comes, Katie will give you instructions as to how to queue up to ask your questions. And as always, if you think of any questions after the webinar, or if there are any questions that you'd like us to follow up on that we weren't able to answer during the course of the webinar, you can email them to us at affordablecareact@aoa.hhs.gov. Again, that's affordablecareact@aoa.hhs.gov. And because we tend to get this question a lot, just a reminder, you cannot print the slides through WebEx. We will post them on our website within hopefully a week or so after this webinar. But if you would like the slides in advance, you can email us again at the same email address, affordablecareact@aoa.hhs.gov. As Katie mentioned, we are recording this webinar. The recording, along with the slides and the transcript, as I mentioned, will be posted on our website as soon as possible. So with the housekeeping now out of the way, we are thrilled to be joined today by the author of the Community Catalyst report I referenced earlier, Putting Consumers First, Promising Practices for Medicaid Managed Long-Term Services and Supports. Alice Demner leads Community Catalyst's work in the key areas of Medicaid managed care and long-term services and supports, and also directs the Substance Use Disorders Project. That collective work seeks to improve the access to quality affordable health care and social supports for vulnerable people by reforming our health care system through direct advocacy in Washington and technical assistance to state organizations nationwide. Alice's background is in investigative and analytic journalism. During 30 years as a reporter and editor, she informed policymakers, influenced public opinion, and spurred change. She won national awards for her health coverage at the Boston Globe, which focused on gaps in care for the uninsured, seniors, and children with mental illness. And I should also mention, I think Alice will talk about this as well, but Community Catalyst is a national nonprofit advocacy organization working to build consumer participation in the healthcare system. So with that, I will turn things over to Alice to start the substance of our webinar.
Thank you so much, Marisa, and good afternoon all, or good morning. So as Marisa mentioned, I'll be tackling the subject of promising practices in Medicaid managed long-term services and supports from the consumer perspective. That is, how can we make these programs work best for consumers? Next slide, please. So as Marisa told you, Community Catalyst is a national organization. We're based in Boston. And next slide, I'll tell you a little bit more about us. So our goal is high-quality, affordable health care for all. And we work towards that goal in a number of ways. One is through issue campaigns to achieve public policy changes. And we have worked extensively on the Affordable Care Act. We also worked on the reauthorization of the Children's Health Insurance Program. And currently we're working on programs that try to expand the practice of dentistry through dental therapists, as well as working on hospital community benefits. We also work to shape new models of care, and those include working on models of integrated care, including the demonstrations that the federal government is running through the Affordable Care Act for people who are eligible for both Medicaid and Medicare, the dual eligibles, as well as for changes in Medicaid, for example, Medicaid long-term services and supports going to managed care. We also work with advocates in states across the country, and these are mostly state-based consumer advocates who are addressing the issues that are most critical in their communities, and we provide technical assistance to them to help them do their work better. Running through all our work is a focus on collaboration, which we believe is the most productive way to move social issues forward. Next slide, please. So today I'll be covering these areas: the growth of Medicaid managed long-term services and supports, the benefits and risks of that switch, promising practices, and avenues for consumer engagement. And I hope what you take away will be an understanding of the opportunity that managed Medicaid long-term services and supports presents for better care and control of costs, and of the need for collaboration with stakeholders, particularly consumers, in shaping and overseeing the program. Next slide. So Medicaid managed care is growing like crazy. A few years ago, there were only a few states that were doing this, and the estimates are that by next year, about half of states will have shifted from fee-for-service programs to managed care for some or all of their long-term services and supports. And I want to credit Truven Health Analytics and the Center for Medicare and Medicaid Services for this map, which was included in a report that I believe is in the resources at the end of this slide deck. The map shows in the dark blue color those states that were doing managed care in 2012 for long-term services. And in the blue, those new states that were going to move in this direction by 2014, and in the magenta, those that were doing it and are going to be doing more or doing it differently. So we're looking at a big shift. And today we're going to focus on capitated managed care, in which states hire a managed care company to run the program, and that company assumes the financial risk or most of the risk of caring for people. We will not be looking at other forms of managed care, such as primary care case management or the PACE programs. Both of those are good programs, but they're not our focus today. Next slide. So what are the driving factors behind this shift? First of all, there's certainly rising demand for these services as the population ages and as more people are living longer with complex disabilities. Cost, I would say, may be the biggest driver. For states, this is about 1/3 of their Medicaid spending, but according to the most recent statistics, which are from 2009, only about 5% of that spending was in a capitated managed care system. There are also many failures of the fee-for-service system that are driving this change. Those include fragmented care, uneven quality, and even failing to keep people healthy. The demand for community-based care is also a factor here for shifting care from our nursing homes to home and community-based settings. This is both required by the Americans with Disabilities Act as well as what consumers are really want and are more and more demanding. And finally, there are federal incentives and federal flexibility that have come through the Affordable Care Act and through other means. So there are expanded options for state plans and for waivers. There is the demonstration for dual eligibles that I already mentioned, and there are also Affordable Care Act incentives to rebalance that care from nursing homes to the community settings. Next slide. So is the shift positive or negative? Let's take a closer look. So on the benefit side, I would argue that the potential benefit is better care with an ability to control costs. And that would come from one, expanded access would be a way to improve care. A number of states have used their managed care programs to expand particularly home and community-based services and to eliminate waiting lists. And Hawaii and Wisconsin are two states which did use their managed care programs to eliminate the wait lists. I must say Wisconsin has reinstated their wait list, unfortunately. Also, states are adding services. For example, Delaware recently made the switch to managed care in this sphere and added services including home modifications, homemaking, and home-delivered meals that had not previously been benefits in its program. States may also find that they are able to rebalance more easily. Tennessee has made no secret that the managed care has helped it overcome strong nursing home opposition initially to rebalancing and shifting care to the community setting. Also, there's the opportunity to improve quality and coordination to address the fragmentation that occurs in the fee-for-service system. And this is the improvement in coordination comes particularly when there is an integration of medical care and long-term services. And one example there of a place where there really has been a significant reduction in avoidable hospitalization is in the Senior Care Options Program in Massachusetts, which really there has been some studies that have shown that by really providing people care earlier, they have been able to reduce that hospitalization and reduce also some use of nursing homes. And finally, some possible improvements in efficiency through stabilization of costs or at least making the costs more predictable. Some states have said that they've actually been able to save money through their systems. Texas says they have saved money on acute care because of going to managed long-term services. And Wisconsin Family Care said they saw savings through reduce of nursing home use. But I would caution that many states have not saved money without restricting services or hurting consumers. So if they have saved it, they've come at some cost. So this is one of the reasons I think that there are cautions, and we'll get to some of the other risks in a moment. Next slide, please. So I wanted to share with you during the course of the presentation a couple of stories of real people just to ground us in what we're talking about here. And this is a story about really how managed care can be a success for consumers. This story comes from a report that Governing Magazine online did about this shift in care. So this is a story about Dolores, who was 86 years old and had had a long, active life, but was beginning to develop a number of different illnesses, including diabetes and dementia. And she was juggling about a dozen medications for those conditions while living at home in Tennessee. And one day while juggling, she dropped a few balls, and she ended up in the hospital from a problem with her medications. So once she was getting better, doctors said, they didn't really feel comfortable sending her home to the same situation she was in, that she needed supervision for the day, for every day, and that they saw two options for her. One was to go to a nursing home, and the second was to have all-day supervision at home. Well, neither her son or her daughter-in-law could quit their jobs and stay home with her, so they really felt like the only thing open to them was a nursing home. So Dolores went to live quite unhappily in a nursing home that was paid by Tennessee's Medicare program Medicaid program, called TennCare. So, her family sadly watched as they saw her decline as sort of year after year went by. And then Tennessee began to implement its Choices Managed Long-Term Services and Supports program. And Dolores' life took a much better turn. Choices worked with Dolores and her family to set up a care plan to get her home and putting together the services she needed, which included primary care and then a registered nurse who comes to check up on her at home once a week, PT at home twice a week initially and then externally, and more importantly, an aide from 7 to 5 daily. So Dolores now is actually getting out for walks. She's going to her hair salon again. She's visiting with neighbors. And in short, she feels she's got her life back. Next slide, please. But unfortunately, managed long-term services isn't always such a success story. There are many for-profit companies who are seeing this as a great new billion-dollar market on which they can operate. And they may make money through efficiency, which would be great, but they also may make it through cutting back or cutting services. And at the same time, many states are setting savings targets for these programs before they even start enrolling people and see how they're going to work out. So the results can possibly be service gaps, growing wait lists, poor quality care, virtually the opposite of giving people the opportunity to live with dignity and as much independence and community participation as possible, which we would hope would be the goal. Another risk is to community providers who have long been working in the long-term care market, and that they would be squeezed out by larger systems of providers, and consumers then forced to shift from those providers to strangers to them. Problems could also result from lack of knowledge among Medicaid officials and MCOs about how long-term services are different from acute care. Also, the programs may reduce consumer-directed care or person-centered services in a misguided attempt to exert control. And finally, state and Medicaid staffs may be stretched too thin to provide proper oversight. After all, they may be juggling ACA implementation and various innovations while also trying to manage existing programs, all while the governors and lawmakers in their state are clamoring for budget reductions. So it can be a problematic mix. Next slide, please. So how can we ensure better outcomes? I pulled together a set of promising practices that can perhaps help minimize the risks and maximize the benefits. And in doing this, I've drawn on the many resources and papers that others have done that have looked at the states currently managing long-term services and supports. As well, I've drawn on conversations with experts and on the experiences of consumers and consumer advocates. Some of the resources that have helped to inform the paper that I've written and this presentation are included in the list at the end of this presentation, and you can find the full list in the endnotes of my paper, which is also in those resources at the bottom, at the end of the presentation. I'll also be citing during the presentation some states that are implementing these promising practices. With programs constantly evolving, I'm sure that I'm not presenting a complete list of the best practices or promising practices. So during the Q&A period, it would be great to hear from those of you on the call about other examples as well as new developments. Next slide, please. So we'll start with promising practices in designing a Medicaid-managed long-term services program. Next slide. So from the start, it's essential to engage consumers and consumer advocates in planning the shift to managed Medicaid long-term services and supports. Consumers and their advocates bring crucial experience in what is needed and what works. And I would argue that the state's first step should be to develop a plan for consumer and stakeholder involvement. And it's important for this involvement to continue through implementation, through operations, and through the oversight phase as well. So what does this mean? So again, we would recommend starting with the creation of a state oversight and planning council that is at least 50% consumers and their advocates. Massachusetts, in its duals demonstration, has established just such a council with very broad responsibilities. States can then add on other ways for consumer and engagement, including focus groups, surveys, task forces, and open community meetings. You need a variety of these kinds of methods to really gather broad input and to build support for the change. Health plans also need this consumer perspective to help inform their decisions. States should require each managed care company to have a robust plan for consumer engagement. We suggest requiring the plans to have at least 25% consumers on their boards, and the Wisconsin Family Cares program is one example of having that requirement and how it works. An alternative, although I would argue perhaps not as useful, is having a designated consumer advisory committee with direct access to the plan's top officials. A number of states are moving in this direction of having either consumer advisory committees or consumers on broader stakeholder committees. Unfortunately, advocates tell us that these requirements are not always enforced and that some officials are not as attentive as one would like. For these boards and committees to work, a few steps are really critical. Meetings must be physically accessible and linguistically and culturally appropriate. For example, community meetings should be held in the language that is spoken in the particular community you're in. States and plans should also provide staff for these committees and stipends for time and travel to make member participation possible. And in case this sounds like an impossible task, there actually is precedence for this kind of support for committees. The regulations for Medicaid medical care advisory committees, in fact, require this kind of stipend if necessary to ensure consumer engagement. Next slide, please. So all the changes required to set up a program are not ones that can be thrown together quickly. CMS, in fact, recommends a 2-year process for implementing managed long-term services and supports. Tennessee took 3 years, securing buy-in from stakeholders, working with health plans, and ensuring that everything was ready before they began. Hawaii was also very deliberate as well, although there it took a consumer push to get an advisory committee established that turned out to be very critical in shaping the program. The focus of planning and the focus of the program needs to be person-centered, maximizing the consumer's control, choice, and independence, and listening to the needs of those who will be served. And states need to bring in the experience of those who know long-term services and supports, which may include the state's Office on Aging and Disabilities and those who have been involved in waiver services. Assessing managed care readiness is also required, the readiness that is of the companies, that is required by CMS. And within these reviews, it's really important to pay careful attention to the extent and quality of the LTSS experience of these plans and to make sure that they're ready for the task. Medical loss ratios are another tool that can be used in planning and for these plans. They're not as common as we think they should be in Medicaid managed care, but states are moving in this direction. Ohio, in its duals demonstration, has set a 90% medical loss ratio for plans. And just to clarify what that is, that means that 90% of the capitated payment that the MCO is receiving must be spent on actual services as opposed to overhead or profit. And so in Ohio, if the plans fall below that level, the rules that are being set up would have them face a fine and perhaps a requirement that they forfeit revenue to Medicaid and Medicare that they would otherwise be able to pocket. Next slide. So one key aspect of planning is setting up mechanisms to ensure that needed services are provided quickly. I offer an example of what we want to see avoided, and this is provided by advocates in one of the states that has gone to managed care for long-term services. So Julio is an 87-year-old who lives alone and has difficulty walking and also some cognitive impairment. Under a waiver program, he was getting 6 hours of home care a day, but it wasn't enough. His daughter was staying with him overnight whenever she could, but given her other responsibilities, she was burning out. When his state switched to mandatory managed care, he was assessed and the state authorized 24-hour care. He and his family were really relieved. But then the months ticked by without any change. 3 months later, he's still waiting, caught in a snafu about how people in a waiver program are transferred into the new managed care program. These are issues that need to be worked out in advance. Next slide, please. So another step in planning is deciding how the managed care will be structured. At Community Catalyst, we believe strongly that integration of long-term services with other services is really key to providing the greatest benefit to consumers and also the greatest efficiency. Arizona, Massachusetts in its Senior Care Options Program, and Tennessee are among the states that have integrated their managed long-term services with acute and behavioral services. Most of the duals demonstrations are also moving in this direction. An alternative that can work is for the state to require the long-term services plan to serve as the overall care coordinator. New York, in its voluntary managed long-term care program, which is now being superseded by a mandatory program, had followed that model. And Wisconsin Family Care does currently require plans to coordinate with other Medicaid services and to serve in that function. Next slide, please. How the state handles enrollment is a critical factor. We believe strongly that voluntary enrollment, where consumers must actively opt in, is the best way to ensure consumer needs. Because the plans really have to be attractive enough in that case to bring in consumers. Both Minnesota and Wisconsin have shown that this can work. Minnesota, in its long-running senior health options, has enrolled 36,000 members, about 2/3 of those eligible. And Wisconsin Family Care enrolls about 33,000. A second, in our opinion, less desirable option is one in which consumers may have a period to choose a plan, but then are automatically enrolled if they have not chosen. In this option, often called passive enrollment, the consumer retains the right to opt out. A number of states are using this option, particularly for the dual-eligible population. Finally, many states are mandating enrollment with no allowance for opting out, and we believe this model is most likely to fail in serving consumer needs. For all these options, but especially for the passive and mandatory options, we believe additional consumer protections are essential. These include phasing in the enrollment to allow time to deal with problems, using multiple means to get the word out, letters, websites, calls, meetings, and perhaps most importantly, trusted community-based organizations with no financial interest in consumer choices to educate the public. Wisconsin uses aging and disability resource centers in this capacity, and others may find it good to use independent living centers, area agencies on aging, and even recovery learning communities, which are a development coming out of the mental health and substance use disorder community as a way to really help people get back into living normal lives. Finally, we believe it's really important to allow consumers up to 90 days to make their choice of plans before they are assigned. And California is using this model for its duals demonstration. Also important to use smart assignment, which is coming to be a term used for assigning consumers based on the plan that has most of their current providers. Next slide. So it's really also important to set up the program with as broad a range of long-term services as is possible. That would include all Medicaid state plan services, as well state plan long-term services, as well as all waiver services for long-term services. And a number of states are taking this route. Also important to extend the covered services to those that are needed to keep people in the community. And this may include things like an air conditioner for an apartment that would otherwise be sweltering. And finally, since more than half of those getting long-term services in some states have behavioral health needs, peer support and recovery services are also an important part of the network. And finally, there should be no waiting lists or caps on services. Next slide. So a diverse and robust network of providers is also essential, and many states have recognized this. These providers need to be culturally and linguistically competent, accessible for people with disabilities, and trained in independent living and recovery learning philosophies. It's also critical that they be experienced in long-term services and supports. The programs need to incorporate the long-established aging and disability service providers who know this population and what to do. And a few states have moved in this direction. Massachusetts, in the Senior Care Options Program, requires the plans to contract with geriatric social service coordinators from the AAAs. And in Texas, STAR Plus has required plans to enroll all current providers for 3 years. As with other forms of managed care, monitoring network adequacy is also key. States are increasingly using mapping programs to track distribution of providers and using calls or visits to providers to check availability. Arizona, Tennessee, and Texas are among those who use those secret shoppers to check on the network adequacy. States also need to ensure continuity of care for those who have been receiving long-term services already. One important way is to permit consumers to continue seeing providers for at least a year, even if those providers are not in the new network. California and Ohio, in their duals demonstrations, are going down this path. Also, states should require the MCOs to allow individual exceptions to network rules where those are needed for the consumer's health. And again, in the duals demonstration, Massachusetts is allowing these single case exceptions. Next slide. So I'll pause here and see if there are any questions so far, Marisa, that we should address.
All right, thank you, Alice. I've been able to take care of most of the questions, but I do think there's one that I'd like to pose. You touched on it really briefly just within the past couple of minutes, but it may be worth expounding on a little bit. And this question comes from Norma, who asks if there's a role for subcontracting with managed care plans for aging and disability resource centers or other kinds of community-based organizations such as Centers for Independent Living and so forth.
Sure, that's a great question. I think absolutely there is a role for subcontracting. I think that there are sort of two big roles. I think that there are two big channels that, for those organizations to participate, and we would argue that it's really important for them to participate to make these systems of care work. And one would be to be actually hired directly by the state to perform some functions. And I think the second would be to be subcontractors to the managed care companies to perform specific functions, and we'll talk a little bit about that in a moment, whether it's care coordination or, as I mentioned earlier, is it outreach, part of the outreach and enrollment effort, or as service providers, since I know some of the AAAs, for example, serve a dual role of both being connectors to services as well as being service providers, and the same thing for the independent living centers.
Okay, so we got a question from Alexandra who asks, how does Medicaid managed care integrate with current waiver-based long-term services and supports? Do you tend to see the same agencies or different agencies providing coordination and oversight?
Again, another good question. I think there are different models. Different states are pursuing different models. Often, when states implement managed care, they often try to sometimes, what is the word I'm looking for? Consolidate waivers, and so there's sometimes a role where the managed care company is taking over the role of others that had in the waiver, and then other states try to keep them separate, or they keep a part of the system separate. It's quite common, actually, for example, for developmental disability and intellectual disability long-term services to be carved out and to continue as a separate waiver program.
Okay. A question from Althea. How do you see managed care organizations incorporating the services supported within participant-directed waiver programs, such as what you talked about earlier, I think, such as the purchase of an air conditioner for someone who may need it in order to remain at home and so forth?
Sure, and I'm going to talk about that also a little bit going forward, but I think it's really important that to incorporate those. But I think there's a tension there, and that's one of the things that I think states are still working through, how to make that work, because the impetus, or for not the impetus, but the MO of some managed care companies is really to try to manage, and it's sort of at odds with the idea of consumer direction. So I think figuring out how to balance that so you don't lose consumer direction, which I think is a very important part of long-term services and supports, is something that I think is still being worked through, but needs to happen.
Okay. I think oops, hold on. Another great question from Barbara, who asks, how have you seen in the states that you've looked at, how does local HUD senior housing intersect with these initiatives, particularly regarding training staff and who are maybe new to the concept, or with regard to resident or consumer input?
I don't have the answer to that question. It's not something I looked at, and I'm wondering if maybe later in the Q&A there's someone on the call who could speak to that. And otherwise, I will try to get some information and pass that through Marisa to folks.
Okay, great. And I think we've covered, I'm just scrolling back to make sure I haven't missed anything. I think we've covered just about everything we've gotten so far. We did get one question which actually provides a great segue into the next section of this presentation, and that is that you mentioned ombudsman, and she was wondering how plans have used ombudsman, or states have used ombudsman in relationship to managed care organizations. But maybe this is a great spot for us to move on, and we can take any other questions that come in, in our next Q&A segment at the end.
That would be great, and if we could hold that and see if it's answered by, I'll be talking quite a bit about ombudsman later, and if not, please ask a specific question on ombudsman again. So shall we go on?
Yes, go right ahead.
All right, so we're going to turn now to, how do you run these programs, and what are some issues and promising practices in running these programs? So I would say one of the first things is really to make sure that the program is promoting home and community-based services. Since, caring for people in the least restrictive setting is federal law under the Olmstead decision of the Supreme Court, and that should be explicit in the contracts with the managed care companies. And in making that explicit, states can take some of the steps that I've outlined on this slide. So for example, they can hold plans responsible, and we would argue that they should, for the full nursing facility stay of any person in the system. And one reason that's very important is because if you have nursing facilities carved out, as some programs do, you have, unfortunately, a perverse incentive for the plans to put people or encourage people to go into nursing facilities, because then it's not on their bill. And so it's unfortunately works against the idea of promoting community-based services. Secondly, states can pay plans the same whether the person is in a nursing facility or in the community, and this is called using a blended rate. And in some states, including Arizona and Tennessee, they build into that blended rate an assumption that use of nursing homes is going to go down compared to the previous year. So they're already building in that rebalancing into the rate. Third, require the plans to reduce waiting lists for home and community-based services as part of what they do, and that's been used in a couple states to quite well. And finally, to really make sure that you're monitoring for any reduction in long-term services and supports. And California has plans to put that in place for its duals demonstration. And we would add that there's sort of another element of that we haven't seen in operation yet, but would be important, which is to ensure that the percent of spending, long-term services spending in the community stays stable or increases over what it was in the fee-for-service system, so that you are rebalancing as you're implementing the home and community-based services more. So any of these mechanisms can be combined with federal incentive programs which can operate in fee-for-service or in managed care that enhance the rebalancing. And these include the Money Follows the Person program, the Balancing Incentive program, and the Community First Choice program, among others. And several states have used, as I mentioned earlier, managed care to rebalance. And in fact, Tennessee effectively combined its Money Follows the Person and its managed care capitated formula to double the number of people it was serving in the community in just a few years. They still have a way to go, but they have made a significant step. Next slide, please. So another real important part of the program is that once consumers have chosen a plan, that their needs and preferences are fully assessed by someone who is knowledgeable about long-term services, but who will not financially benefit from the decisions made. We believe the best practices here is to use an agency outside the MCO, for example, an ADRC, a AAA, independent living center, but most states permit plans to use their own staffs to do these assessments. We think it's best to use the standardized assessment, and in fact that's recommended by the Balancing Incentive Program of the federal government. A number of states are beginning to develop their own standardized statewide assessments. Also, the assessment should be comprehensive. It should include not only the person's illnesses, but it should include their physical and mental functional status, their quality of life goals, and their personal preferences. It should also consider socioeconomic status, accessibility of services, existing supports, and many other factors. I would cite as an example the Washington Comprehensive Assessment Reporting Evaluation, which is also cited as a model practice in the Balancing Incentive Program implementation model. Finally, assessment is something you really can't do well by phone. Arizona is one of the states that not only requires in-person assessments, but also requires plans to initiate services within 30 days of people signing up for the plan. And they've shown this is doable. Plans met that standard 97% of the time for people living in the community in fiscal 2010. Next slide. So long-term services work best in managed care when the services are well coordinated, especially when they're coordinated broadly with other services, as I mentioned earlier. So a promising practice here is having an independent care coordinator, someone who is conflict-free, again, not a provider or employee of the MCO. And Massachusetts expects to offer this kind of coordinator as part of the interdisciplinary team that each consumer will have in its duals demonstration. This long-term services coordinator would be chosen from a community-based organization and would help assess long-term services needs, help develop an individualized care plan, and also be the liaison with service providers and the managed care company. A new state law, in fact, specifies that the MCO may not have a financial interest in this community-based organization serving in this coordinator role, and that the community-based organization may not be an LTSS provider unless it is granted a waiver by the state health secretary. Of course, the details of how this will operate are still being worked out. A second step would be to develop and follow an individualized care plan for each consumer. Fortunately, many states are using this promising practice. These care teams should have the power to authorize specific services so that they can quickly head off problems before they lead to avoidable hospitalizations or nursing home stays. And Texas STAR Plus is one of the few that empowers its coordinators in this way, so they can authorize services without having to go back to some sort of central utilization review authority. And finally, care coordination works best with lots of one-on-one contact. Arizona and Wisconsin require visits to consumers at least every 90 days. And I think many states would find that even more frequent contact would work better. Next slide. So Joe's story offers an example of the problems that can occur if you don't have a point person for the care team who can quickly authorize services in that way. Joe has dementia, yet he still lives at home with his wife. She supports the two of them with her cleaning job, and they depend on long-term services to take care of Joe while she's at work. On a typical day, the aide comes to help Joe with his morning routine, and then he goes to a day program, and then he gets help again from an aide in the late afternoon until his wife arrives home. So one day this winter, he woke up with what seemed like the beginning of the flu that has been going like wildfire through all our communities. Before Joe's home state shifted to managed care, he would automatically get to stay home with an aide if he was sick. But on this day, his wife also thought it would be better if he stayed home. But the home care agency under the new managed care program said they didn't have an MCO authorization to stay home with Joe. So they sent him off to the daycare center. When Joe's wife tried to get authorization so this didn't keep happening, she and an advocate helping her were referred back and forth over a period of more than 2 weeks among 5 different people, including an MCO nurse coordinator, a caseworker, and various MCO social workers. No one stepped up to solve the problem. Fortunately, Joe didn't infect everyone at the daycare center the days he was there sick, and didn't get sicker himself. But his wife really felt this was not good care. So she switched him to another MCO and is hoping that the new plan will be more responsive. So when shifting to managed long-term services and supports, it's important to have the option of consumers directing their own personal care services, including hiring and firing personal care workers. As someone asked before, how is this working? Well, it actually is happening in at least 12 of the 16 states that were doing managed care in 2012. And as part of consumer-directed services, many of these plans are training consumers in how to oversee their own workers to help them take on this role. and also training them in how to help care for themselves. So it is working in many states, despite the fact that there is this tension between among who has the control. If the consumer requests it, we think family members should also be trained and paid to be personal care assistants. And there are at least 3 states that are doing that. And my guess is this is, again, a growing phenomenon as people recognize that this is an important role that family members can play. Managed long-term services and supports can also provide respite services to help shore up family members, whether they're paid or unpaid, who are serving in a caregiver role. Next slide, please. So let's turn now to monitoring. Since there are many, many moving parts with one of these programs, oversight is really a critical function once the plan is up and running. Next slide. So to start, states should require plans to meet robust quality and performance standards. And as many of you know, the national standards are under development for LTSS. But states are moving ahead with their own measures because they need them now. And some are tracking preventable hospitalizations and nursing home placements, tracking whether there's timely assessment and implementation of care plans, and also doing consumer satisfaction surveys. Promising practice is also to include assessment of the consumer quality of life and the degree to which service needs are being met, degree to which there are changes in functional status, whether there are disparities as a result of ethnicity or age or disability, to what extent care coordination is occurring in a positive way, and whether rebalancing is continuing. My colleagues at the National Senior Citizens Law Center in California have just put out a guide to LTSS outcomes measures, which I recommend to people to read. And I believe there may be an upcoming webinar that addresses that issue as well. So states should also survey all consumers with an LTSS-specific tool and conduct face-to-face interviews with a subset of consumers to go deeper in depth as to what's happening. Currently, there's in development a CAPS consumer survey for home and community-based services, which will be probably very helpful to states in the future. In the meantime, states can look to Wisconsin as one example of the breadth of measures that can be used in a quality of life survey. Wisconsin's Personal Experience Outcomes Integrated Interview and Evaluation System, or P&Es, like the flower, includes questions in 12 areas, including whether the consumer is living in his or her preferred setting, making his or her own decisions, working or pursuing other interests, maintaining relationships, and whether they're comfortable with their own health. The Center for Healthcare Strategies has recognized this survey as a promising practice. States should also incorporate these performance measures into MCO contracts and tie payments to quality using incentives or penalties. Arizona, Tennessee, and Texas are among those that do this. Texas, for example, includes a withhold part of the capitated fee, and managed care companies can win that back if they meet certain quality standards. And finally, to keep the public eye on quality, states should publicize the details of their quality and performance assessments of MCOs in an accessible fashion for the public. So turning to ombudsman, we think it's really important that besides the state doing direct monitoring, that the state should establish and fund an independent ombudsman, preferably by contracting with an organization that is already trusted to represent consumers. Alternately, the state could expand the role of the federally required long-term care ombudsman from focusing on institutional care to including all of long-term services and supports. In Wisconsin, in fact, they use both methods together after consumer advocates pressed for an ombudsman during the move to managed care. The state contracted with Disability Rights Wisconsin to operate an ombudsman program for people 18 to 59 getting Medicaid long-term services and supports. Ombudsmen across the state handle individual cases, while a program manager identifies systemic problems and has been able to secure some statewide improvements. In addition, the state enhanced the role of its long-term care ombudsman to include complaints from people 60 and older getting community-based long-term services and supports in addition to institutional-based care. For the duals demonstrations, advocacy groups including Community Catalyst have come together to recommend a model that also includes consumer education and empowerment in addition to individual complaint resolution and identifying systemic problems. In a paper laying out the recommendations, we suggest possible designs, criteria, and payment options, and discuss existing models of managed long-term care and other managed care ombudsmen. This document can be found on the Duals Democracy website listed in the resources at the end of this presentation. Next slide. So other consumer protections that are also important include streamlined grievance and appeals, rigorous contract oversight, reducing care only with state approval, which is something that Delaware has put in place, enforcing compliance with the Americans with Disabilities Act and with the Federal Mental Health and Substance Use Disorder Parity Act, and adhering to standards for cultural and linguistic access, and finally transparency on contracts, on outcomes, and on spending and MCO rates. And in fact, Minnesota's governor has set an example for that kind of transparency by requiring internet posting of all contracts for managed care companies and reporting on managed care finances, reserves, provider rates, and patient outcomes on a reader-friendly website. Next slide. So as we discussed, there are many phases to implementing managed long-term services and supports, which are depicted here. And I include this slide as a possible checklist for people to assess if consumers are being engaged in all of these phases. Next slide. So my final message to you is this. Proceed with caution on managed Medicaid long-term services with awareness of the potential benefits and the risks. There is an opportunity for better care and control of costs, but to work you need to put consumers first. Collaboration with consumers and with stakeholders is essential, as is vetting the design carefully of the program and vetting the ability of the MCOs to run the program. And finally, it's very important that states retain strong oversight over the program and not just turn it over to the managed care companies. Thank you so much for the opportunity to share all of these suggestions with you. I look forward to hearing your questions and your comments.
All right, thank you, Alice. We have lots of time left for questions and answers, and we've been getting lots of questions in through chat. Let me first go through the resources section of the slides really quickly. As always with our webinars, we have included several slides worth of resources that were both useful in terms of preparing for this webinar, as well as other related links that can provide additional information on the topics we've been addressing today. So first, on this first slide, we've got several resources, including the report on which this webinar was based, that come from Community Catalyst, as well as some other consumer engagement and consumer advocacy publications that they have put out. We've also included resources from other partners, the toolkit that the Disability Rights Education and Defense Fund and the National Senior Citizens Law Center developed in looking at long-term services and supports, beneficiary protections in a managed care environment, as well as the National Association of States United for Aging and Disabilities, State Medicaid Reform Tracker, and some other reports and frameworks that deal with managed long-term services and supports and integrated care. We've included several Kaiser Family Foundation resources, and this is probably actually a really good point for me to mention again that hopefully none of you are frantically trying to scribble down these URLs because many of them are long and complicated. We will be posting our slides on our website within the next week or so. We'll post the slides, recording, and transcripts on our website as soon as possible. However, if you would like to get a copy of the slides sooner than that, please do feel free to email us at affordablecare.aoa.hhs.gov. Again, that's affordablecare.aoa.hhs.gov. And I'm be happy to send you a copy of the slides sooner than that if you would like. We've included some CMS resources, resources that have been put out by their Medicaid Coordination Office, also known as the Duals Office, as well as a resource kit that they put out related to managed long-term services and supports, and the report that Alice referenced earlier when she was talking about looking at that map of where managed long-term services and supports had been implemented or was being developed in a number of states. And as always, we've included some general Affordable Care Act resources in here, including a link to our health reform web page, which is where we store the recordings, transcripts, and slides of all of our webinars that we've done for the past couple of years. So with that, we will continue our webinar series next month, and we will be looking at quality and managed long-term services and supports, focusing on a report that was just issued by the Disability Rights Education and Defense Fund and the National Senior Citizens Law Center looking at this topic. We'll send out our registration info in early to mid-February, so please do watch your email for more information. We're looking at February 26th, I believe, for this next webinar on quality and managed long-term services and supports. So with that, I will, we've gotten several questions in through chat, but I do want to give people who are only on the phone the opportunity to ask questions as well. So Katie, if you could instruct people as to how they can queue up on the audio line to ask questions, that would be great.
Thank you. We will now begin the question and answer session. To ask a question, please press star, then 1, and record your name at the prompt. Your name is required to introduce your question. To withdraw your request, please press star 2. One moment, please, as we wait for the first question.
All right, so while we're waiting for that first question through the audio line, we got a question in from Sandy. Actually, we got this in from a couple of different people in the audience who asked if you could talk a little bit about or present examples of states' managed long-term services and supports programs that include people with developmental disabilities, because some states have been known to carve out persons with developmental disabilities. She was wondering if you could talk about any examples from the research that you did of those that did include people with developmental and intellectual disabilities.
I will have to get back to people on that because I should have used a disclaimer at the beginning. That was not an area that I focused on. I deliberately did not look at how the developmental disability population was handled, not because of any disinterest, but as a way to make the research manageable in a short period of time. I think across the country, many states have carved out the developmental disability and intellectual disability population. So I cannot offer you an example. I can get back to you on that. Or maybe there's someone else on the in the audience who would like to address that by raising their hand.
Okay. Katie, have we gotten any questions, anyone in the queue for the audio line?
I'm showing no questions at this time.
Okay, well, we'll keep going then with the questions via chat. We got a question from Jeanette who asks if you have any best practices or recommendations on consumer appeal rights regarding managed care organization decisions related to assessments, service authorizations, wow, that was tough to say, and a choice of providers.
I'm sorry, could you repeat that question?
Sure. Jeanette asks if you came across if you developed any best practices or came across any best practices or had any recommendations related to consumer appeal rights regarding managed care plan decisions on assessments or service authorizations or provider choices.
Yes, we do have several recommendations on that. Certainly, one is that those those appeal processes need to be really accessible and simple, and there I really cannot point to a state that has managed to do that. They're unfortunately mostly incredibly complex. It's critical that the states provide care while the appeal is pending, and I know that that has been an issue in many states. I believe New York, under its voluntary managed care system for long-term services, has done that, but I believe that there is some discussion in the new dual demonstration in New York about not carrying that over into the Medicare part of the program. So I think those are a couple of best practices that I would recommend.
Okay, we got a question in from, we got several questions related to assessment, so let's tackle a couple of those. One from Althea, who wondered if you came across any states that looked at, within their assessments, family health or situational health.
Situational health, yes, I believe that is part of the, well, it's part of that P&E survey in Wisconsin, and some of the plans in Wisconsin use that as part of the assessment tool. Others use it only as like a quality control tool afterwards or a checkup, but I believe it is included in that, and I think some of the more robust assessments that are processes that are being developed in New York, for example, I think will include that. I'm not sure that any of the others do currently.
Okay, so along similar lines related to assessment, we got a question from Tom who asks about how states are assessing the cognitive abilities of participants through their assessment tools. Are they using separate tools? Are they integrated? You know, what types of tools are they using? Because dementia could play a major role in all of this and the extent to which people can manage care or may need to rely on caregivers and so forth.
Absolutely, and I think in terms of that, it was sort of whether they're doing testing with the individual or they're using caregiver information. I think states are using a combination of those as you know, in reference to what the specific tool that they're using. I did not collect information at that level, though I imagine it's probably available.
Okay, Darla asks if the extent to which states are including, states and plans are including day services, such as adult day services and so forth, within plans, given the concern that, you know, people may become isolated if they're homebound.
Right. So a number of plans are including day services, both because it tends to be a fairly efficient way to help provide care for people, and people like the social aspect of it. So I think there is a movement towards that, and we've certainly seen it in a number of the duals demonstrations that the long-term services component is very much including that as an option for care.
Okay, I'm just scrolling. Okay, why don't we turn back to Katie and see if anybody else has queued up in the audio line.
I'm showing no questions at this time.
Okay, I am going to keep scrolling through. Okay, Bill asked a question with regard to the extent to which you came across or any recommendations that you all may have with regard to guidelines that states should consider with regard to workforce development or training for family and paid caregivers through plans or through the state's managed long-term services and support systems.
So I'm going to address those two separately, unless Bill was looking at them together, because I think there's certainly a big piece of workforce development, which is very critical to making these programs work, because there is growing demand, as we said, for these services, and not, for the most part, not enough folks in the community workforce to take care of them. And so there are a number of initiatives underway. The PHI, which is a national organization that works on issues of workforce and worker rights within this arena, has a major plan that they have laid out, which I would heartily recommend people take a look at for workforce development. And some states are really experimenting with, how can they encourage this development with career ladders and other efforts of that sort. And actually, I would just, as an aside, just mention there that also very important, and the person had asked earlier how HUD programs intersect with managed long-term services, and I would say that states are also trying to find ways that through the managed care system or through coordination with their own housing efforts, how they can develop the affordable housing that's needed to enable people who want to live in the community to live in the community, who may have lost their homes because they were living for a period of time in a nursing home, or whose current homes may not be the appropriate setting for them, even with supportive care. As far as training for family caregivers, there are several states, and I think we don't have the stuff memorized. I don't know if we can go back to the slide. I think we had a couple of states that were mentioned that are doing that training for family caregivers. They're among the 12 where personal care services include using family care members.
Let me go back and see if I can get to that slide right now. I think here we go. So we got a question. Let's see. I'm just scrolling through. Any questions through the audio line, Katie, at this point?
I'm showing no questions at this time.
Okay, everybody's busy on chat, so I'm scrolling through right now. We actually, with regard to the question we had earlier related to managed long-term services and individuals with intellectual disabilities and developmental disabilities, we got actually some input from our audience. Yeah, I know. So Alan mentions that there are managed long-term services and supports programs for individuals with DD in Wisconsin, Michigan, Vermont, and Arizona through not-for-profit managed care organizations, also North Carolina, and others are emerging in other states as well. So there's the answer to that question, or at least a partial answer. There are also other resources and reports that have come out looking at managed long-term services and supports and individuals with developmental disabilities and intellectual disabilities in different states. So if the questioner wants to email us at that email address I mentioned earlier, Affordable Care Act @aoa.hhs.gov, I'm happy to send you links to some of those resources. So I'm looking to see if there's anything else. Okay, so here's another question from Jennifer, who asks, beside respite care, do states or state-managed long-term services and supports programs, did you come across any that included services for caregivers that might address the health and well-being of caregivers as part of the service packages?
I did not, but I believe that there are. I think that I have since heard that there are several, some states that are combining that the respite with those kind of services, and I would refer people for the answer to that question to the National Caregivers Alliance, which I think is maybe tracking that area.
Okay, I'm looking to see if there's, I know we got one other question. Just bear with me while I scroll up. Okay, so we got a question from Betsy, who asks if you all had any recommendations that you would make to community-based organizations such as area agencies on aging and centers for independent living and the like, as to how they can sort of, as she puts it, keep themselves in the mix and really be relevant to as states begin to look toward this shift to managed care?
Great question, and I would say one of the things that's really important is to, as much as possible, get in in the planning phase, to talk to state officials, to talk to consumer advocates, and really to try to be at the table so that you can help be part of shaping it. So I would say that's one important thing, is not to sort of hang back. The second, I would think, is really important to demonstrate through whatever means you have possible with previous reports or presenting consumer stories, so the skills and that what you do have to bring to the table. And finally, to look at a number of the states that really have gone out of their way to incorporate community-based organizations into these programs, and to highlight those examples for the folks in your state who may not be aware. And finally, I would say I think some of the associations of various types of community-based organizations have been getting very much involved in this, and so if you're not already a member of one of those organizations, for whatever type of community-based organization you are, you might look to see if they're engaging in a way that could help you.
And that's a great, actually, segue into talking a little bit about, certainly we've been, the Administration for Community Living has been addressing issues related to managed long-term services and supports through this webinar series, as you've heard today, and hopefully you heard on previous webinars last year. But we've also provided some funding to 3 national organizations, the National Association of Area Agencies on Aging, the National Association of States United for Aging and Disabilities, and Boston University, to provide some training and technical assistance related to building the business capacity of aging and disability community-based organizations, although NASHUD will be targeting state organizations and how they fit into this mix. But N4A and Boston University will be looking at building the business acumen of community-based organizations in order to sort of play a role in this new managed care world that we're living in when it comes to long-term services and support. So there'll be more on that coming out in the coming weeks and months, but that is something we're also looking to address as well in some of the technical assistance that we provide for our partners. Okay.
And Marisa, if I could add one thing, I just saw in the last couple of days that SAMHSA, the Mental Health and Substance Use Disorder Agency, had also just put out a grant announcement for grants to, I believe, state-based organizations working in those arenas at the community level to try to do the same kind of thing.
Yes, for those, if there are any organizations that are behavioral health organizations that are on this webinar, SAMHSA has been becoming very active on this front. They have what is known as their BH Business, Behavioral Health Business Initiative, which is looking to form learning networks that are focused on targeted issues related to building the business capacity of community-based organizations to participate in health reform efforts. For those of you who may be interested in that, your primary mission does need to be behavioral health oriented, but feel free to email us at affordablecare@aoa.hhs.gov, and I can provide you with a link to that effort. I believe the applications are due next week, so there's not a lot of time on that, but I can certainly provide you with a link to that effort if anyone is interested. Okay, so let's see. Katie, any questions through the audio line?
There are no questions at this time.
Okay. We got one more question in from Robin, who asks, I know you touched on this a little bit, Alice, as you were talking about promoting home and community-based services, but if you could maybe go into a little bit more depth about what states are doing with regard to how money follows the person in nursing home transitions sort of fit into state-managed long-term services and supports programs. I know you touched on it in the example and a little bit in your slides.
Sure. So I think a number of states are looking really to try to dovetail the two approaches because it's particularly important where states have had such an institutional bias to their programs to figure out constructive ways to help people move back into the community, and that can be really challenging within a managed care environment where you have a capitated fee. Where do you find the money to help people make that transition, to provide them with the funds they may need for first month's rent, or to help them set up whether it's an apartment or a unit in assisted living, et cetera. And those are the things that the Money Follows the Person funds can be used for very effectively. So it's really trying to couple those. And I don't have the list of states in front of me that are doing that, but as I mentioned, Tennessee had really effectively done that, and I know there are a number of other states who are doing very similar things. And again, there might be someone on the call who has that list or a few other states in mind, and we would love to hear from you if there is someone who knows some of the other states off the top of their head.
I believe that may have been mentioned in the Truven report that you had referenced earlier when we put up the map early on in your slides. I think they talk about that as well, and they have a listing of states that are doing some of that work. Do you just from what you do know about the work that states are doing related to Money Follows the Person and managed long-term services and supports, is it the plans that are handling, the managed care organizations that are handling those transitions, or are they looking toward community organizations to continue to do that work that may have been started under MFP?
I think there's a mix, is what I understood, and looking at it, that some cases, the role of managed care companies in this, all of these things varies greatly from state to state, and there are in some states, the state is really asking the managed care company to take that on, and whereas I think in another state they're continuing in the other way. And thank you for pointing out that the Truven report did look at that issue, and I think might have some information on that question as well, Marisa.
Okay, great. Katie, one last call for any questions that may have come up on the audio line.
There are no questions at this time.
All right. Well, I think we have covered all of the questions that came in via chat. So with that, I want to say thank you to Alice for a wonderful, thought-provoking presentation, and thank you to our audience for such terrific questions. They've been sort of coming in fast and furious throughout the course of this webinar. So if anyone on the webinar thinks of any additional questions, or if you have suggestions for future webinar topics, particularly related to integrated care and managed long-term services and supports, we very much want to hear from you. So please do email us, and I'll repeat this email address one last time, at affordablecareact@aoa.hhs.gov. We very much want these webinars to be as useful to you as possible, so we do welcome your suggestions. We thank you all for joining us today, and we look forward to having you with us on future webinars. Thank you very much.
That concludes today's conference. You may now disconnect.